We'll move on to Dr. Kumar. Doctor, as I told you, he's from Mumbai, a great exponent of and an early adapter of phacoemulsification technique, and he has had the use of the catalyst as also the Zemer, but he'll be talking about managing the hard cataract. So the hardest cataract I've ever done. Kumar, over to you.
Thank you, Maipal, for giving this opportunity to me. And I want the panelists to look at this slide that I'm going to show and your opinion. And this is truly the hardest cataract that I've ever done in my career. So this is the right eye, and this is the left eye. So I tried all different slit lamps. I have an upper, I have a Topcon, and the maximum light that you put on your slit lamp and try to go through the anterior capsule, you can't see the posterior capsule. So you can't see the posterior convexity of the lens at all. So whatever you try, whatever instrument you try, you can't go through this, okay? So now the question here is, what will you do? Please remember this image because there will be questions asked at the end of it. So question here is, what IOL will you give? Of course, profession, night driving, whatever questions you want to ask. But will you do an ACC, SICS, ICCE, phaco, or flax with phaco? So panelists, if some of you have seen the image, I can show it to you. It's on the left-hand side. What technique will you use for this? Can 111 answer from that side? Shreyas? Or you'll refer to your neighboring best friend and make him your best friend forever?
I would still attempt a phaco, sir. If it's, I mean, it's a well-dilated pupil, and if the bag is not too weak and pseudo-exfoliation is not there, then
no
it's likely that
good bag.
Likely that phaco is still very much possible.
Maipal?
Flax.
Raghav?
So definitely femto, and definitely have a bigger axis.
And Gaurav?
I would choose a femto as well, for sure.
Tityal, sir?
The femto may be my choice, but recently, I shifted to a pre-fragmentation with my loop and phaco subsequently.
Great.
That's another option.
So this is the video that I'm going to show. I've hidden the name for a particular reason. But what is important to here to notice is that there is absolutely no glow coming from any angle of the eye. So you can see that there is zero glow. As you can see on the slit lamp, it was a very, very, very hard cataract. So here I've done flax, as some of you already believe in it. I'm now using the Z8 system, no financial interest. The advantage of that is we can increase the energy in each step. So if you have a very hard cataract, you can make your laser energy 120, 140. And if you have a softer cataract, you can reduce the energy. Obviously, more the energy, more the time, more the cavitation bubbles, etc. Now I'm under topical anesthesia, but remember one thing, when you have a very hard cataract and you have done flax, I prefer to use a dye. Sometimes you may not get a perfect CCC all around, and that can be caught on if you use a dye. So here you can see that I'm putting in the dye and making sure that the CCC is complete all around, and if the CCC is complete, and of course, you have to use a good viscoelastic. In this case, I've used Viscoat, which is understood. And at the same time, once all this is done, go ahead, remove the bubbles. Once that is done, make your main incision. And you can see that I'm making sure that the CCC is free all over. So once the CCC is done, now one battle is won here, because if case anything ever happens, we have the CCC to protect us. Now you are not going to be able to see your fluid wave at all, because it's a very, very dense cataract, which is understandable. So a very gentle hydrodissection. Make sure. Now again, in flax, the biggest advantage is you have a little bit of bubbles behind. So when we inject fluid, the fluid wave will find that bubble plane. So you actually have about 600 microns of cortex, in this case nothing, sitting above the PC, and this will help you in your hydrodissection. So flax does one big advantage, that it assists you in your hydrodissection, because the fluid wave will find that pneumatic plane. Once that is done, we go all around, and then we start our phacoemulsification. So you can see, again, the tip here would be to use a new tip. Use a brand new tip. If you already know that this case is going to come tomorrow, make sure that a brand new tip is autoclaved. You can see the shine coming out of the tip. That will help your phacoemulsification much more. Now, I've done fragmentation. In fragmentation on the Zimmer, we don't have cubes. We have two rings, or we can do sectors. So here I had done 6 sectors, which I normally stick to, or you can do 8 sectors. But the more the sectors you do or the more fragmentation you do, the more time it would take. So here you can see that, of course, the best trick is to go deeper, keep injecting viscoelastic. Once the viscoelastic injected, use the chopper, go all around. So here I'm going ahead and doing this. So again, you can see that it's easy to rotate. Once you can get your rotation quite easily, once again inject viscoelastic, make sure that you kept the endothelium safe and continue to do your phacoemulsification. So here you got one fragmentation which we had gone through the flax, going ahead, holding the nucleus, and again I'm getting that groove which was done with the help of the femto, and then you can see the separation. Once that has gone around, I'm going to go all around this and then go ahead, and you can see it's a very, very dense nucleus. Once this is done, we still go ahead, go all around. I'd like to make sure that the central deep bowl is quite deep enough so that the hardest part of the cataract is really removed. Once this is all done, don't forget I'm under topical anesthesia. This is doing well. At this time, I'm going ahead and doing the last part of the fragmentation. Once I've made sure all the pieces are separate, again inject epitrate or adrenaline intracameral and viscoelastic, protect your endothelium, go ahead and do your phacoemulsification and remove one piece. So you can see that I've removed first one piece. Once I made sure all the pieces are separate, once that is done, go ahead and do your phacoemulsification, remove one piece, remove the second piece, and then that's done. And once that is done, you will see that there is hardly any cortex remaining. So you can see this, and once this is done, go ahead and do the last part of the phacoemulsification. So once we have done all of this quite easily, then do your bimanual IA. Now there is a reason why I'm showing you this, because there will be some questions asked at the end of the presentation. Do your bimanual IA and then implant an IOL. Now you'll be surprised, the IOL I implanted, I had never implanted this lens before. It is a Rayner EDOF lens, so I was just doing my bimanual IA, very little bit of cortex, and you can see that the CCC is good, intact. Inject again viscoelastic, make sure that you created your space, remove the subincisional cortex with the bimanual IA. Once that is done, we'll go ahead and inject the IOL in the bag. So here we are putting in the IOL, which is the Rayner EDOF lens. I've used Rayner lenses, but in this case, it was used for the first time. So now I'll ask a few questions, and that's what I will want an answer to. So you can see that the surgery is successfully completed. And of course, patient was very happy, the reason being he came back to me for the second eye. So we have some questions here. How old do you think this patient was? Quick, one-liner. Shreyas.
Considering that you're asking this question, I'm tempted to say 40, but normally I would expect it to be 75 or 80.
Yes, Raghav?
It's about 65, 70.
Maipal?
As old as you are.
I'm not going to disclose the age then. Okay, we skip that question. So, what do you think was the vision in each eye? You saw the image before, right eye and left eye?
So I'm presuming 618, 624 with a myopic shift.
Perfect. So patient was 618 and 624. How many viscoelastics you think are used in this case? 5. I don't get it free like you, Maipal. So I used 3 viscoelastic and BSS plus. One more question I want to ask. What do you think was the profession of this patient?
Did you kill the BSS?
Yes.
Profession of the patient?
Yeah,
he was an ophthalmologist.
Perfect. He's an operating ophthalmologist.
Wow.
And the Rayner lens was got by him. So I had no choice in lens selection. He said he wanted that lens. And before surgery, I met him in the pre-op, and he was taking a pill. And I asked him, what are you doing? He said, I'm taking Alprex. And after 10 minutes, his wife asked him, do you want another one? So I got tempted and saying, let me also take one.
Yeah.
But luckily, everything went fine. What was the first day post-op vision? He called me in the evening, so I was damn nervous. I thought there will be SK, striate keratitis, 660. And he said, no, I can see reasonably quite well. So his vision, surprisingly, next day was 6/9, and he was N8 and 6 part. And so he got his other eye also done. So I just wanted to say thank you, Maipal, for this opportunity. Thank you, everybody.
Great.
We didn't expect anything less from you. He's a great surgeon, that at least one can say. Any questions, anybody? So anyway, if you want to get your eye operated till his hands work, you can go to Kumar Doctor in Andheri. No charges.
Kumar, I have a quick question for Kumar.
Yeah.
Brilliant job as usual. You've used 2 femtosecond platforms now. You've moved on from one of the previous ones to the new one. What difference do you see, for example, in these challenging cases like this hard brown cataract? Do you see a difference in the way you were using it before and now?
So I've used the Catalyst for almost 5 to 6 years, and now I'm using the Zimmer for 3 years. So I think subluxated cases, I think Catalyst, the softening of the nucleus, the Catalyst does a better job. You can't do cubes on the Z8. But as far as CCC is concerned, both platforms are almost the same. Segmentation, the big advantage I find on the Zimmer is that you can increase the energy. So if it's a very hard cataract, you increase the energy. If it's a soft cataract, you reduce the energy. So I don't know, I never tried it in the Catalyst. Okay, so you can do that in Catalyst, I just came to know. So that's another thing I found good. Otherwise, big advantage of course, between the two systems is the portability. So the Z8, you can shift from one center to the other or wherever you want, and it still does everything. So it's a all-in-one instrument which does everything.
For that, you'll have to make new centers. Anyway, I think...
excuse me, can I?
Sorry?
Can I question?
Yeah,
Please? Okay.
sure.
Do you count the endothelial cell before and after?
Yes, we have a specular since many, many years, and we do specular for everybody. Yeah, we did count the patients fine.
Okay.
Did have a few spots. The patient knew, obviously, he had done his specular before also, but he knew about it. But because of BSS Plus and Viscoat, I was quite well protected, and patient did well.
Perfect. Thank you very much.
See, actually, if you do the phaco in the proper plane, you don't do it supracapsular, and you avoid being nearer to it, and then you're using the chondroitin sulfate and you're using the femtolaser platform. These do very well. I don't know whether you were there or not, but I showed a harder cataract than this, a black cataract, and the patient did very well again. Patient was 6'9" next day.
Okay. Thank you very much.